Welcome to Knowledge on the Go, the podcast brought to you by the Performance Improvement Programs team at Vizient. In today's healthcare environment, organizations are working to deliver high-quality care while improving efficiency. Their focus is on reducing variation and supporting long-term sustainability. Joining us today to discuss supply variation reduction is Marcy Maddox, Executive Director of Supply Chain with the University of Missouri Healthcare. I'm Shannon Hale, Senior PI Program Director at Vizient, and your host. Marcy, welcome to the podcast.
Thanks, Shannon. I'm excited to be here.
Yes, looking forward to the conversation. You are a subject matter expert on our Reducing Supply Variation Collaborative. Why was it important for you to work with us and our members on this project? And why is this such an important topic in today's healthcare landscape?
It was important, Shannon, for me to participate. Being labeled a subject matter expert feels sometimes a little uncomfortable. Am I really that capable? And then I realized I do, no matter what level of maturity you are in your supply chain, you have the ability to knowledge share what's worked well for you or where you have more opportunities. I'm passionate about it, and it's something that as an organization, we're trying to fundamentally instill into our culture. From a health system perspective, why it's so important is we aren't unique. Our peers are in the same boat where we're looking at those cost pressures and the clinical quality. How do those coexist and how do we manage those together? One of the biggest opportunities we saw as an organization was looking at supply variation, and not just limited to the number of vendors in a space, but how we're using those supplies as well.
With your work so far in the collaborative, have there been any ahas or light bulb moments for you? Anything that you found?
Absolutely. I've tried to listen to my peers and also the conversation and the chats that have happened during our collaborative meetings. One of the biggest aha moments for me was it's not just about the product, it's really about behaviors and alignment. How do we engage the clinicians that are utilizing the products to have meaningful conversations so that we can actually take action on whatever kind of category or project that we're doing? I like to leave projects better than I found them, but I always find with collaboratives, whether I'm a subject matter expert or participating, I always learn something every meeting, and I enjoy that.
It's funny because we do surveys with our collaboratives, and whether it's a benchmarking survey, collaborative, or a one-off, maybe member spotlight, et cetera, we're all working towards that one goal of improving care for our patients. It's often something that you'll see in those surveys. I love the sharing. I loved hearing what this organization's doing. I'm going to try that in my organization. One recent area that we hear almost weekly about being a struggle, regardless of what type of project you're working on, improvement project, is getting buy-in. Have you found anything in your work there at Missouri that may help those listening?
We have been very fortunate in transparency as an organization. We have tried to create a culture or to endeavor on a clinical variation project several times. It wasn't until about 6 months ago where our chief medical officer, we went in from a supply chain perspective and said, this isn't a supply chain project. This is a clinical project, and we want you to drive it. But here's the framework of the methodology that will work best. Now, debate me. Let's talk about how this will work, where we need to tweak it, and let's get it polished so then we can take it to the rest of the clinicians and say, this is what we're going to do. Having that top level support where the CMO says, I'm behind this. Let's get you a physician champion that's a little closer to the work. Have them be the boots on the ground. Then let's socialize this across the organization has been the most important and key driver for us being successful. I'm proud of the team that we've built. And now we even have physicians that are like, hey, I want to be a part of that. Let's look at this category, or can we do this project? What are your thoughts?
You have those additional clinicians coming in. Do you think it's because they've seen success in what you've been doing to this point?
Absolutely. They've seen projects where before it probably felt like taking something away. I don't get to use what I've always used, or I have to pick a vendor and I like both vendors and it's not clinically driven. Where we've created this methodology where we sit down and we look at it, and it may not make any sense to limit vendors. but it may be more looking at how we're using those supplies. We've tried to be very careful about making sure that we start with, this is what you look like today in this category of spend. What are your thoughts? Where do you think we have opportunity? We let them really drive. And then we usually go away, grab some data, come back together and say, we validated that with data, or here's what we really found. How do we shift? How do we pivot so that we can make meaningful change?
You mentioned earlier that sometimes you don't see yourself maybe as a subject matter expert. And I think we all deal with that day to day. But obviously, you've done some great work there. Are there any steps that you've found in your work that have helped to ensure success?
Patience. It's hard, right? It seems very overwhelming. It's organizing your work. We leverage the Vizient spend categories, and that's how we organize our work. And we look at our price index and we carve that out and align that with our contract roadmap. Just knowing where we're starting was an important piece of it. Get that physician buy-in, knowing how we're going to organize the work. We are very fortunate to have a strong financial analytics team that helps us marry that clinical data with our financial data. We can go in and say, this is what we look like from a spend perspective. These supplies are being used in, and these are the physicians that are using them. These are considerations that we may need to give. And that's been very helpful.
I'm going to throw one thing at you. I mentioned the buy-in piece. We hear that almost weekly. There's also a second thing that we hear a lot. I just heard it this week. I was in a meeting with members and we heard about sustaining improvement. And the quote from the presenter was, sometimes it's easier to see the improvement than it is to sustain it. In your work, how do you make sure that the improvements that you're seeing are sustained?
It's a hurdle, right? It's a barrier. It's easy to identify the opportunity. It's more of a challenge to sustain those. We track from opportunity identification to planning to implementation. And then we have a follow-up schedule where we go back and we look. And if we see there's some erosion in that opportunity, then we have the conversation. Something we hadn't considered that came up is new requests. You do all of this work in a category, and then there's something new and shiny that somebody wants. How do you make sure that falls in line with the work that you've already done? Through our value analysis team and prioritization pipeline that's for larger scale projects, working really closely with those leaders to make sure we're evaluating all of that work so that we don't 6 months down the road and find all of the hard work done up front has now just completely been wiped out.
It sounds like keeping that data out there, keeping the conversation going once you're seeing those improvements has really been helpful for you.
Very much so.
We've heard that with a couple of other organizations, keeping that data, keeping the story out front, making sure you've got that accountability built in there as well. It sounds like you've got a solid foundation for the sustaining change.
We're talking about what the methodology is. We're talking about the successes, the failures too. What are things that didn't work for us and how did we course correct? Having an escalation path around declined opportunities is vitally important. We've defined between acceptable variation and unwarranted variation. When someone says, I can't realize this expense reduction opportunity or this variation reduction opportunity, it then gets escalated to be vetted so that when we make the decision to leave that on the table, it's truly because we feel like it's in the best interest of the clinical care of our patients.
You mentioned something that a lot of people don't look at, and that's failures. Maybe you tried to do something and it didn't work out as you thought it would. Is there anything that comes to mind the first time you tried to improve something, it didn't work out, but you learned and you were able to get improvement?
I am not afraid of failure. It took me a long time, and I feel like it's therapy saying it out loud. It's scary to tell people I didn't succeed at something, or it didn't happen the way I envisioned it, or how I communicated it was going to happen. Our clinical variation journey through all of the iterations has been a learning experience. This isn't new. We've tried this several times, and each time we take something away from it. And ultimately got to the point where we realized without having that clear methodology and then engaging the physicians to say whether that methodology was going to work for them or not was the point that we went from barriers and not being successful to now seeing success. For the most part, I feel like we're still going to have some product categories where we miss the mark, and that's okay. It'll be taking that and my contract management team and the physicians and saying, what exactly exactly was it that didn't work this time? And let's consider that the next time we evaluate those. It's important not to be scared of it.
How do you as a leader build that into the culture where you've set that as a president? It's okay if things don't work out. We're going to go back and we're going to learn from them.
Modeled. When my team asks me questions and I don't know the answer, I'll say, I don't know the answer. There will be times where I'll make a decision and it may take us down a rabbit hole, or it may take us down a course that then we do have to course correct. And it's just owning that and showing them no buildings imploded, no patients were harmed. That kind of thing is important so that they know they can test the waters too, make decisions, make suggestions, try things out. I'm here to guide my team and make sure we're careful not to make any decisions that could potentially bring harm to our teams, our departments, the patients ultimately, but making sure that they know it's okay. It goes back to talking about the failures, talk about your decision points. We huddle a lot. Just as a team, we have a dedicated weekly huddle, but you'll hear in the office where the team will just say, hey, let's group up. And they'll sit down and they'll brainstorm and they'll talk through, oh, well, when I did this similar project, this worked well, or I did this project and it didn't work as well. We share a lot of information.
I have no doubt just from hearing your response to my question there that culture exists because of the things that you have role modeled there. One of the things that we're doing here at Vizient in 2026 is called Roadmap to Top Performance, and it's looking at studies that two of our executives here have done over the last 20 years or so. And what they've consistently found is that leadership sets the tone. Even if you want to look at a hospital facility, go all the way to the president, and you can see how that tone that person sets goes throughout the entire fabric of the organization. And it sounds like you've definitely done that there with your team.
Thank you. We're really fortunate to have a very stable C-suite that also models that behavior. Above me, our leadership team demonstrates those behaviors, and that's very meaningful and impactful all the way down to the end users.
That's great. You mentioned the end users there, the patients and their families. They would love to hear what you just said. Not only is your team looking to improve it, but all the way to the top. Let's just look at everybody in the organization. We're all, whether we're looking at trying to improve readmissions, improve mortality, ED throughput time, improving supply variance, it's all going back to the patient, to them and their families when you drill it all down. I love that.
And that can be hard from a supply chain perspective. Our teams, they're a little bit more removed from the patient. So the work they do sometimes can not feel as close. We reiterate that a lot in MU Healthcare, where we talk quite a bit about how impactful the work we are doing and is and whom it impacts. And that's the patient at the end of the day.
One of my favorite quotes from an old boss that I had, he used to tell me that even if you're looking at something that's not clinical, let's say you reduce variation by 6%, behind each of those percentage points is a patient. It helped me go back to what it was all about and really see the impact that I was making in my day-to-day work. For organizations that may feel overwhelmed by where do you begin with reducing supply variation, what advice, Marcy, would you offer to help those teams focus on progress without feeling like they have to solve everything all at once?
It's overwhelming. You look at your entire book of business, your spend, your contracts, the work, priorities, fires, all of it. And it can be really hard to take that first step. And I always tell people, don't eat the elephant whole. Let's look at where you are today, who you are as a supply chain. I look at my peers and I have friends who are in different levels of maturity of their supply chain and the work they're doing. And that's okay. That's probably right where you need to be in that moment. And how you move that needle is you acknowledge and you say, this is where I'm at right now. And this is the work that we can accomplish with the team that we have. And you take those little chunks. It's amazing how quick that work snowballs and you find yourself in a different level of maturity in your supply chain evolution. And next thing you know, you're at the next and you're pitching a methodology for clinical variation to your CMO and he's high-fiving you because he thinks it's great. Those are the things that build teams and foundationally build your strategy around supply chain.
It sounds like you have a great culture there within your organization. It really helps with improvement work, with setting the tone for the team. Sounds like a great place.
I'm very proud of the supply chain team. I'm really proud of the organization as well.
I'm going to ask you to look into your crystal ball now. We're going to look at the future, the Reducing Supply Variation Collaborative. It's wrapped up. It's done. What would success look like for you on that project? What would make you stand back and say this was a success?
If we're looking at 18 months, which is really where our target expense reduction is currently set at is 18 months, if we hit that goal, that'll be the first level of success. If in 5 years, that methodology we've leveraged for this big push is still being utilized and recognized, and it becomes the standard of how we manage categories, maintaining our view and our efforts, that'll be successful to me. It goes back to the sustainability. Are we sustaining the things that we worked on in 2025, 2026?
That will really be of help to many people that are listening to here, keeping that data, keeping that story out there front and center so that people are talking about it. Marcy, thank you so much for joining us today. I've really enjoyed chatting with you here and sharing your insights around supply variation. And thanks to you, our listeners. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com.